I want you to try a little experiment with me, just for a second.
Okay.
Go ahead and take your finger and just tap your chin. You feel that?
Yeah, the pressure, the texture of your skin.
Exactly. Now imagine you wake up tomorrow morning, you go to brush your teeth, and you tap your chin, and you feel absolutely nothing.
Like it's not even part of your face anymore.
Right. It's thick. It's numb. It feels exactly like that sensation when the Novocaine hasn't quite worn off after a dentist appointment. But here's the thing.
You haven't been to the dentist?
Not at all.
Yeah.
And for, 99% of people, that sensation is just an annoyance. You think, did I sleep on it weird?
Did I bump it? You just ignore it.
But today, we are diving into a stack of documents that proves that specific sensation, that numb chin, is actually a siren.
A major alarm bell.
We're doing a deep dive into a medical phenomenon literally called the numb chin sign. And to get to the bottom of this, we have a fascinatingly messy combination of sources.
Right. It's not just a clean textbook chapter.
No, we have a very sterile, high-level clinical case study called the Taxonomy of Oral Squamous Cell Carcinoma, and clipped right to it.
Yeah.
We had these frantic handwritten notes from a medical resident.
And honestly, the notes are where the real story is. They're scribbled in this chaotic mix of English, Urdu, and French. It feels like we're looking directly into the brain of a young doctor.
A young doctor who is realizing just how complex and frankly how terrifying this disease can be.
Absolutely.
So here is our mission. We're going to perform a kind of forensic reconstruction of this case. We're going to trace the timeline of a killer, starting from a bad habit, moving to that numb chin, and ending with a surgery.
It sounds like science fiction.
Oh, it really does.
We're talking about taking a bone from a human leg to rebuild a face.
It is a massive feat of dialogical engineering. But you're right, before we get to the solution, we have to understand the enemy.
So let's introduce the patient. The case study gives us the dry facts. An elderly male, progressive, non-healing ulcer in his right cheek. But the notes give us the visceral reality. It's a grim picture. This is not a canker sore. The notes describe severe pain that gets worse when he even tries to chew.
Oof.
There's a distinct foul smell, which the notes attribute to necrotic tissue.
So the flesh is literally dying in his mouth.
Essentially, yes, the cancer is killing the tissue. But the most telling symptom is something called trismus.
Trismus. I see that word circled multiple times here in the notes.
Most people would know it as lockjaw.
Lockjaw. Okay.
The patient literally cannot open his mouth. I mean, the notes here specify his opening is less than 35 millimeters.
35 millimeters. I mean, you should grab a ruler. That's, what, barely 2 fingers wide?
Barely. And that number is a real threshold for doctors. It tells them that this tumor isn't just sitting on the surface lining of the cheek.
It's gone deeper.
It is burrowed deep. It has invaded the pterygoid muscles, the muscles that work the hinge of your jaw. The tumor is physically, mechanically jamming the door shut.
That is a claustrophobic thought. So a patient who can't eat, can't open his mouth, is in pain. How did it get to this point? The notes point the finger at a very specific culprit.
Gutka.
Gutka.
Right. The social history notes a 20-year habit. For anyone who hasn't encountered it, gutka is a chewing preparation, really common in South Asia.
And it's a mix of things, right? Not just tobacco.
It's a mix of crushed areca nut, tobacco, paraffin, slaked lime, all sorts of things. And the user places it in the buccal pouch.
Which is just that pocket between your cheek and your gums.
Exactly. And the problem is the combination. The areca nut is fibrous, it's sharp, it causes these tiny little cuts in the cheek lining.
Microabrasions.
Right. And then the tobacco and the lime, which are carcinogens, seep directly into those fresh cuts. He's been marinating his cells in toxins for 2 decades.
So the Gutka is the predator. But let's go back to our hook, the numb chin. Why is mental nerve neuropathy underlined so heavily? Why is a numb chin worse than the ulcer itself?
This is the critical aha moment in the diagnosis. Your chin and your lower lip get their sensation from a specific nerve called the mental nerve.
Okay.
That nerve doesn't run through the skin. It runs inside the jawbone, through a little canal, and then it pops out a little hole near your chin called the mental foramen.
I'm sort of visualizing the wiring in my head.
So if the chin is numb, it means that nerve is either dead or compressed. But the tumor is way back in the cheek.
So how does it get to the chin?
For the chin to be numb, the cancer must have performed what's called paraneural invasion.
Paraneural invasion. That sounds aggressive.
It is. It means the tumor broke through the hard bone of the jaw, found that nerve canal, and is now using it like a subway tunnel.
No way.
It's growing along the nerve, inside the bone, traveling forward toward the chin.
So the numbness isn't a skin thing. It's a signal that the cancer is traveling through the internal pipes of his face.
Precisely, and that changes everything. It tells the surgeon before they even look at a scan that the jawbone itself is compromised. You can't just cut the tumor off the surface.
The bone is infected with cancer.
Right.
This leads us to the scary-looking code in the file. Stage IVA. The code is T4A N2B M0. Let's break this down. T4A. What's the T?
The T stands for tumor, and T4A is a designation for very advanced. It means the tumor is huge, greater than 4 centimeters, and critically, it confirms what the numb chin told us.
That it has invaded bone.
It has invaded gross structures, like the cortical bone of the mandible or the deep muscles of the tongue, yes.
Okay, so N2B, that's about the lymph nodes.
Correct. N is for nodes, the cancer is on the move.
Right.
N2B means it has spread to a lymph node in the neck on the same side, and that node is significant. It's larger than 3 centimeters.
So it's in the cheek, it's in the jawbone, and now it's in the neck. But then we have M0, and the notes almost seem relieved about this one.
M0 is the only reason we're still talking about surgery here. M stands for metastasis. M0 means no distant metastasis.
So it hasn't spread to the lungs.
It hasn't spread to the lungs or the liver or bones elsewhere. If that letter were an M1, this would be a very different conversation. We'd be talking about palliative care.
Managing pain.
Exactly. But M0 means there is still a chance to cure him.
They have a shot. Okay, now I want to pivot to the detective work section of these notes. Because while the case study is so neat, these handwritten notes are chaotic. You can feel the stress.
That's the reality of medical training. When you're staring at a case this complex, your brain can just overload. So you see the resident using mnemonics.
These little acronyms to organize the chaos. Like this one, SDVO.
Socioeconomic, drug, vaccination, other. It's a checklist for taking a patient's history.
But next to socioeconomic, there's this scribbled phrase in Urdu, and it translates to who will bear the cost.
That is such a heavy human detail. It just stalks you in your tracks. We get so caught up in the biology, the cells, the nerves. We forget the context. This surgery, the hospital stay, the rehab, it's incredibly expensive. The resident is reminding themselves that part of the history is figuring out if this family can actually afford to survive the cure.
It adds this huge weight. And then there's another mnemonic for pain, BOPPCRR, duration, onset, progression.
A standard list. But under R for relieving and aggravating factors, there's a note about referred pain.
Otalgia. The notes mention the patient has pain in his right ear. but his ear's fine.
Perfectly fine. And this is a classic trap for new doctors. The sensory nerves from the throat and the deep jaw converge with the nerves that go to the ear. The brain gets the signals crossed.
He thinks the throat pain is coming from the ear.
Exactly. So the rule is, if an elderly patient complains of ear pain but the eardrum looks totally normal, check the throat.
That is a solid detective tip. So the diagnosis is locked in. They've done the punch biopsy, the gold standard, and confirmed squamous cell carcinoma. They've done the CT scan. Now the team gathers.
For the multidisciplinary team meeting, the MDT.
And the procedure they decide on has a name that sounds like a military strike. The commando operation.
It's a very old school surgical term, but it fits. The technical name is wide local excision with segmental mandibulectomy and modified radical neck dissection.
Yeah, I can see why commando is easier.
Yeah.
Let's unpack this battle plan. They aren't just cutting out a lump.
No, absolutely not. The goal, and it's written in big letters here in the notes, is what's called an R0 resection.
R0. What exactly does that mean?
It means removing the tumor completely, but also with a safety margin of healthy tissue all around it, usually about 1 centimeter.
Oh, right. Like cutting mold off bread. You don't just scrape the top.
That's a perfect analogy. You don't just pick off the mold. You have to tear off that whole corner of the slice to be absolutely sure you got it all.
And if you don't?
If you leave even microscopic cells behind, that's called an R1 resection, the cancer just comes right back.
But in this case, the bread is the patient's face.
Exactly. So to get that 1 centimeter margin, they have to take the cheek skin, the muscle, and a large segment of the jawbone. That's the segmental mandibulectomy.
And while they're doing that, the notes mention this high tension moment called the frozen section.
Oh, this is maybe the most stressful part of the whole surgery. The patient is asleep, the tumor is out. But the surgeon doesn't close the wound.
What do they do?
They send tiny slices from the edges of the cut, the margins, to the lab immediately. A pathologist freezes the tissue, slices it, and looks at it under a microscope right then and there.
So the whole operating room is just waiting.
Waiting for a phone call. The surgeon is standing there with the patient open. If the pathologist calls and says positive margins, it means there's still cancer at the edge.
Then they have to go back in.
They have to pick up the scalpel and cut more. They keep cutting until the margins are negative. Only then can they start putting the patient back together.
That is incredibly intense. And we haven't even talked about the neck yet, the neck dissection.
Right, because of that N2B lymph node. They can't just treat the cheek. They have to clear out the whole drainage system. The notes list levels I through V.
So that's basically everything from the jawline down to the collarbone.
Everything. They strip away all the fatty tissue in the lymph nodes in that area.
And the notes make it sound like walking through a minefield. Spare the sand. Watch the IJV.
It is a minefield. The IJV is the internal jugular vein, the main drain for blood from the brain. Nick that, it's a catastrophe.
MDSN.
The spinal accessory nerve, it controls your shoulder muscles. If you accidentally cut that, the patient can't lift their arm anymore. So you have to meticulously dissect the cancer off of these vital structures.
Off of them without damaging.
Wow.
So let's take a breath. The cancer is out, the nodes are out, the margins are clear. But now you look at the patient and he's missing a huge part of his jaw and his cheek.
A class 3 composite defect, as the notes call it.
You can't just stitch that hole shut.
If you did, he would be horribly disfigured. He wouldn't be able to chew, swallow, or speak. This brings us to the reconstruction. And the notes identify the workhorse solution for this problem.
The fibula-free flap.
Exactly. This is where biology turns into engineering.
They're going to take the fibula, one of the bones from the lower leg, and turn it into a jaw.
Yes. The fibula is a long, straight piece of bone. We can spare a middle section of it without stopping the patient from being able to walk. But here's the problem.
The leg bone is straight. The jawbone is a horseshoe.
So how do they make it fit?
Carpentry.
Literally carpentry. While the bone is on the back table in the OR, the surgeon performs osteotomies. They make these precise, wedge-shaped cuts in the bone, careful not to damage the blood vessels attached to it.
And those wedges let them bend it.
It allows them to fold the bone, segment by segment, to match the curve of the patient's original face. They build a neomandible.
But here's the thing that blows my mind. Bone is living tissue. It needs blood. If you just stick a piece of leg bone in the face, won't it just die?
It absolutely would. That's why it's called a free flap. They don't just take the bone, they take the artery and vein that supply it.
Oh, okay.
And this leads to the most delicate part of the entire, say, 12-hour surgery, the microvascular anastomosis.
Which is a fancy way of saying plumbing.
Very, very tiny plumbing. Using a microscope, they sew the artery from the leg into a branch of the facial artery in the neck. We're talking about vessels that are 2 or 3 millimeters wide.
And the stitches.
Thinner than a human hair. And it has to be perfect. If that connection leaks or clots, what the notes call flap failure, the blood supply stops.
And the new jaw dies.
It turns black and dies within hours.
That explains these frantic post-op notes. Monitor flap every hour, check color, check Doppler.
Exactly. The resident has to check that blood flow every single hour for the first 2 to 3 days. It's a marathon of vigilance.
Now, the notes also mention a reconstructive ladder. The leg bone is the top rung, the biggest gun they have. But I saw some other terms for smaller defects, like lip sharing. What is that?
Oh, that's fascinating stuff. Let's say the cancer was just in the lip. Lip sharing, or an Abbey flap, involves taking a triangle of tissue from the healthy bottom lip.
The whole thickness.
The whole thickness, then you rotate it upwards and sew it into the gap in the top lip. But here's the trick. You don't cut it completely off.
You don't. How does it stay alive?
You leave a tiny bridge of tissue, a stalk, that contains the blood vessel. So for about 3 weeks, the patient's lips are literally sewn together.
Oh.
The blood flows from the bottom lip up the bridge to keep the top patch alive. Once the top patch grows its own blood vessels, you just snip the bridge.
That is wildly creative. It's amazing what the body can tolerate.
It is, but I want to pull us back to the science of the cancer itself for a moment. In the pathology section of the notes, there's a detailed breakdown of bone invasion patterns.
Right, we know the cancer ate the bone, but apparently how it eats the bone matters. I saw terms like erosive versus infiltrative.
Think of erosive as a pushing front. The tumor grows and just shoves the bone away, creating a smooth, scooped out shape. It's bad, but it's kind of contained.
And infiltrative.
That's the nightmare scenario. The tumor breaks into little fingers and enters the bone through all the tiny porous spaces.
And there were 2 specific visuals used here, dendritic and pipe stem.
Dendritic means it spreads like tree roots, often going through the dental sockets. But pipe stem, that connects directly back to our num chin.
How so?
Pipe stem invasion is when the cancer gets into that nerve canal we talked about. It runs along the length of the canal like a pipe cleaner inside a pipe.
That is the mechanism of the numbness.
It's the cancer running freely through the bone's internal tunnel system.
And there's one more number circled in red. DOI, depth of invasion. Why is 9 millimeters the magic number?
DOI is essentially our crystal ball. It measures how deep the tumor has penetrated, and the data shows that once the DOI is greater than 9 millimeters, the behavior of the cancer just
It
changes.
gets more aggressive.
The risk of it spreading to the lymph nodes skyrockets.
No.
So if the biopsy says 10 millimeters deep, the surgeon knows they must do that neck dissection. The depth dictates the surgery.
So the surgery's done, the leg bone is in the face, the vessels are flowing, but the section in the notes titled Post-Op Reality makes it clear the fight isn't over.
Not even close. The recovery is grueling. The notes list complications like child leak.
Child leak, that sounds unpleasant.
It is. On the left side of the neck, there's a major tube called the thoracic duct. It carries lymph fluid, which is milky and full of fat from digestion.
Here.
If that duct gets nipped during the surgery, you have digestive fluid leaking right into the neck wound. It causes major nutritional problems.
And on top of that, the patient has a tracheostomy, a hole in the throat,
Yeah.
because the swelling in the mouth is so bad they can't breathe.
Correct. And we can't forget the leg. Donor site morbidity.
Right.
We fix the face, but we damage the leg. Patients can have ankle instability, chronic pain. It's a major trade-off.
And then the final kick, adjuvant therapy.
This is the reality of stage IVA. Because of those high-risk features, the bone invasion, the big lymph node surgery alone isn't enough insurance.
There could still be cells hiding.
Microscopic cells, yes. So once the wounds heal, he has to endure post-operative chemoradiotherapy, a double hit of chemo and radiation to sterilize the field.
It really puts things in perspective. This whole journey started with a habit, gutka, and a subtle symptom, a numb chin. And it ends with a commando operation and months of recovery.
It's a journey of immense physical cost. The medical engineering is miraculous, but it's all an attempt to restore something that was lost to a preventable cause.
So let's bring this home for everyone listening. We've waded through the notes, the staging, the surgery. If we have to distill this down to the absolute essential red flags, what are they?
There are 3 ominous signs mentioned in these sources that should trigger an immediate alarm. Number 1, trismus. If you cannot open your mouth fully, do not ignore it.
Get it checked. Number 2.
Otalgia. Ear pain when your ear is perfectly fine. It's almost always recurring.
And number 3, the star of our show.
The numb chin. If your chin goes numb and you haven't had a dental procedure, that is a red alert for nerve involvement.
The notes leave us with one final scribbled rule at the very bottom of the page. It says, early signs, any ulcer greater than 2